Good morning and good afternoon. Welcome to the workshop, Men's Sexual Health After Transplant. My name is Jordan Sexton, and I will be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Jeffrey Albaugh. Dr. Albaugh is a board-certified advanced practice urology clinical nurse specialist with over 30 years of experience caring for men and women with sexual problems. He is also a board-certified sexuality counselor. He currently works serving our nation's veterans at Jesse Brown VA Medical Center in Chicago and was previously the Director of Sexual Health at North Shore University Health System. Dr. Albaugh is the author of the book, Reclaiming Sex and Intimacy After Prostate Cancer Treatment. Please join me in welcoming Dr. Albaugh.
Well, thank you so much. I really appreciate the opportunity to present, and thank you to all of you who are here with us today and those who listen in the future. I'm really happy to share my information and my insights from my many years of experience. I've been working with men and women with sexual dysfunction for over 30 years. My only goal today is really to enlighten and empower you with some of the information you need to move you forward in your journey towards healing. I really appreciate the opportunity to be here. Everybody's welcome. And also, I want to say, when I speak about, you'll see even in my title, men, we're really referring to people with penises. And so if you don't identify yourself as a man, in the literature and everywhere, unfortunately, those terms are what are used. So when we use that term, that's what we mean. But all are welcome. And we don't want you to feel like you're not acknowledged or you're excluded because you don't identify as a male or a man. That is okay. It is absolutely part of the patients that I see, and I'm happy to answer questions for anyone and everybody. And so regardless of your sexual identity, your sexual orientation. And so you'll hear often I refer to people as partners. And you may have a partner or partners, and all that's okay. This is a no judgment zone, and we definitely don't have any judgment in my clinic because you're already pretty brave to walk into the clinic or walk into a talk. You didn't have to walk in; you got to do it virtually today. But to be a part of a talk on sexual health, because there can be a lot of stigma around it. But that's just what we're going to talk about today: is sex. Hopefully. You'll find it interesting and entertaining as well. I hope if we can't keep you awake with a talk about sex, I think we've got a big problem today. But we are going to talk about a lot of things, and so feel free to ask questions. I will have time to do those at the end. We can even stop in the middle and answer questions if there's burning, pressing things. So this is about you and your journey towards healing, and I want to help you in any way that I can. So yeah, it's been a really interesting journey, and I do work with a lot of different patients with all different medical issues. Certainly a lot of patients with oncological or cancer issues, and so my area of expertise is really urology and sexual health. I also do some couples counseling as well at the VA, and so I'm happy to share information about any and all those subjects with you today. But so it's been kind of funny story. I think I've been called pretty much everything in both of my clinics. So patients will always tell me, "Hey, I always get a kick out of what do they call me in the community." And so often they will tell me, "Oh yeah, we call you this or we call you that." So an easy one that they call me quite frequently is Dr. Love, and I can own that. That's good. But patients have also told me, I do see men and women, but the male patients had told me one time that in the community they referred to me as, and I thought this was pretty creative, as the penis whisperer. I thought that was kind of a creative title to call me. Interesting. But at any rate, I do work with a lot of people with penises who may or may not identify as males. And so we're going to talk about a lot of different things today, and I hope all of it is helpful to you. I'm going to move along. And so we're going to start with Masters and Johnson, who did this incredible, really cool research. In fact, we'll never be able to do research like it again. I do a lot of research. My PhD is in sexual health research, and oftentimes when outside people like the government come in to look at what we're doing to make sure everything's choose my research because it's sensitive, because it's on sexual issues. Masters and Johnson did this sexual research where they paid people to have sex in front of them or masturbate. They learned an enormous amount of information, and it was incredibly enlightening, but you can imagine that would be really difficult to get through an institutional review board in this day and age with research. But they learned so much, and I'm so grateful that they did the research they did. But they say that it starts with excitement. It's sort of like this desire is there, this excitement, and that sort of builds. Your pulse increases, your blood pressure increases, your tactile sensation, the sensation on your skin increases so you can feel more and feel better, and excitement occurs. That builds and builds, but we don't want it to go on forever because we don't want our pulse to keep going up, our blood pressure to keep going up, those kinds of things. So we reach a plateau where it feels really good, it feels really fabulous, but we haven't had an orgasm yet. And some people like to hang out in that plateau area for a while where it's feeling so good, so wonderful. And then it can build to orgasm and then resolution. Sometimes in women, they may be multi-orgasmic, so that orgasm phase may happen several times before resolution. But you can see a little problem here. You might see the problem that on this slide that in that men take about 2.8 minutes average without trying to delay or doing anything special from start to finish, and women take about 13 minutes, a 4 times longer disparity. So it takes, in general, these are generalizations, a woman with female parts who identifies as whatever way they do with those female parts about 4 times longer to reach climax than it does a male if she's partnered with males. And so a little bit of disparity there. So a lot of men, to overcome that, will make sure that foreplay is based on their female partner so that their female partner is either on the brink of orgasm or already orgasming before very much stimulation is done on him, so that then climax can be synchronized. And sometimes that can be important for people. But that's the sexual response cycle according to Masters and Johnson. It's a bit more based on the male model than the female model, but that is the model that they came up with, and we've learned a lot from it. It's not perfect, but it does give us some good information. So what happens? Here's what happens with people with penises. Basically, it starts with stimulation, psychogenic, which means in your mind, as well as on your body, tactile, on the skin. So stimulation on the penis, on erotic zones across the body, as well as sexual thoughts. These sexual thoughts are integrated in the brain along with the stimulation, and that travels down the spine to the peripheral nerves and then to the penis. So there's a communication loop between the penis and the brain and the penis back and forth. That nervous conduction between the brain and the genitals is essential for both men and women, because when that nervous conduction is interrupted, sexual dysfunction can occur. So this leads to what happens eventually is the genitals become engorged with blood. In both the male and female anatomy, the genitals do become engorged with blood. In the penis, there's 3 cylinders in there that all become full of blood, and those cylinders, as they fill with blood, press up against the superficial veins and lock the blood in the penis so that you have an erection and it stays. Any disease or condition that impacts blood flow or nervous conduction, either one. So what could impact blood flow? Well, the really common comorbid conditions are high blood pressure, diabetes, cholesterol, anything that could affect blood flow. But also sometimes blood disorders can affect blood flow as well. So some of the different blood disorders, sickle cell, multiple myeloma, different things could potentially affect blood flow. Nervous conduction, so like the conduction between your brain and your penis or genitals, and so that conduction also, so like lower back problems like lumbar disc issues are very common, or any kind of head, neck, or back problems, but also if you had radiation that hit those peripheral nerves. So my prostate cancer patients who have had surgery where the nerves had to be pulled off the prostate to get it out, or had radiation, those patients will definitely potentially have issues with nervous conduction between brain and penis. And if you've had any kind of radiation or anything that might damage nerve conduction, some chemotherapeutics might cause neuropathy or nerve damage. So any of that could cause problems with nerve conduction. Blood flow and nervous conduction are essential to erectile function. So there's several different types of male sexual dysfunction disorders. There's a desire disorder where a patient has low libido or desire. Now, desire is made up of a lot of different things, so we have to kind of pull it apart, and I do with patients. I try to see what is really going on. So what you do about desire is very different than your desire. So if you think about sex like most men every day, often multiple times a day, that's all normal. But what you do about it, having sex with a partner or partners or masturbating or any of that, is very different than the sexual thoughts or desire. So when we think about desire, we're thinking more about the sexual thoughts, the need for sex, the push towards sex. Hypogonadism is a syndrome where you have low testosterone along with symptoms of low testosterone, and those symptoms could be erectile dysfunction, but they could also, a hallmark sign is lack of sex drive. You don't think about sex much anymore, but you can also have decreased energy, decreased mood, decreased concentration, fatty weight gain, lots of different symptoms, but usually several symptoms along with the low testosterone would be what hypogonadism is. So those are the desire disorders. Erectile dysfunction is the inability to get and keep an erection hard enough for sexual relations with a partner. So you can't get and stay hard enough for sex. Even on your own, you know when you can get and stay hard enough, and that is what erectile dysfunction is. An orgasm disorder could be either premature ejaculation, where it happens too quickly, you have no control over it, it causes distress, often happens within a minute or less of vaginal penetration. Some men have the opposite problem, which is difficulty reaching climax, and that can be from, again, nerve damage could certainly cause that. The blood flow can get into the penis, but if you have nerve damage, sometimes it affects both erections, getting hard, because that requires the communication between brain and penis, and ability to reach climax or orgasm. So that's a couple different things so you understand the classifications of male sexual dysfunction disorders. The most common one by a landslide that brings men into the clinic is erectile dysfunction, inability to get and keep erections sufficient for sex. But I do see all the different disorders. Sexual dysfunction, what happens after transplant? Why are we even here today talking about this? Well, it's really, really important, and I really salute the people who plan this conference, because oftentimes sex and intimacy is overlooked because there's so many other really critical, important things to talk about. But this is also a part of the human journey, and so I'm really glad that they include these topics in the discussions pretty much each year, and they invited me to share my expertise this year, which is in sexual health and working with patients with sexual dysfunction. But why are we talking about it? Because 62% of transplant patients and 79% of partners reported that sexual function had not been discussed with them. So nobody really asked them or talked to them about these issues. And we know from research, too, patients are reluctant to bring it up with their providers as well. Erectile dysfunction rates, though, despite the fact nobody really asked or talked to him about it in that study, and that study parallels many studies that have been done with multiple patients about discussions around sexual function with oncology and cancer patients as well as other patients. Erectile dysfunction rates, though, were, look at this, we got over 68% prior to transplant related to other treatments aimed at achieving remission status, so the things that were done before, chemotherapy, radiation and stuff, and then jumped to 100% 1 month after transplant. Then, thank heavens, was down to 60% 1 year after. But we see the majority of these patients will struggle with sexual issues. But are they being addressed? So that's why we're here today, to talk about it. Most often men reported erection and ejaculation issues. And that makes sense because you think about it could affect blood flow, it could affect nervous conduction, and erections and ejaculation are dependent on proper nervous conduction back and forth between brain and genitals. 57% of men, and you see there's several different studies here. Again, 57% of men in this other study, completely different study, reported significant sexual issues. So we see well over half the men report problems. multiple studies showing that sexual dysfunction adversely impacted quality of life. So this has an impact on your life. It does affect things. It is part of the human journey to be sexual. And it's okay if you aren't sexual or don't want to be sexual. That is okay too. But if you do and you're not able to function, it can really impact quality of life in some of these men. Multiple studies show that sexual dysfunction, and so we've talked about how that affects quality of life, but the large majority of men had abnormal hormone levels, mostly elevated luteinizing hormone, or LH, or follicle-stimulating hormone, FSH, and that's going to affect testosterone. It may also affect things like estradiol, estrogen in your body. It may affect prolactin, different things. 38% had decreased testosterone levels, and testosterone, the main function is it gives you your drive, your sex drive. It has a very small role in erections, and it has a small role in climax, but it has a big role in desire and sex drive. So that's important to remember when you think about testosterone. Testosterone deficiency is not really only about 5% of men with erectile dysfunction we can relate the cause back to hormonal things like low testosterone. So low testosterone is not the main reason for erectile dysfunction, but it is one of the main reasons for a lack of desire, a lack of sexual thoughts, and drive towards sex. So what about the CAR-T cell therapy as well? Let's talk about that. But before we do, you know all this, but I want to briefly just say that when we talk about a blood stem cell transplant, that's it's a hematopoietic stem cell transplant, but it can also be called a bone marrow transplant, a stem cell transplant. You all know this better than I do because you've lived through this, certainly. But it can be autologous, where they use stem cells from yourself, or it can be from a donor or a twin. But prior to the transplant, patients typically receive high doses. I'll go back for just a second before we talk about CAR-T therapy. So patients often receive high doses of chemotherapy and or radiation to destroy their disease and make room for healthy new blood stem cells. If the dosage of chemotherapy and or radiation is high enough to completely suppress the patient's immune system, then that's called a myeloablative transplant. But it can also sometimes be reduced in intensity to a non-myeloablative transplant. A blood stem cell transplant is used most often to treat patients with multiple myeloma, leukemia, non-Hodgkin's lymphoma, Hodgkin's lymphoma, myelodysplastic syndrome, and also not as often, but sometimes genetic or inherited disorders like sickle cell disease, thalassemia, immune deficiency diseases, Wiskott-Aldrich syndrome, several different things, neuroblastoma, lots of different things it can be used for. So I wanted to go through that just a little bit before I move on to the, CAR-T cell. So now when we talk about chimeric antigen receptor T cell therapy, referred to as CAR-T cell therapy, basically that removes T cells from the blood and inserts a new gene into them to make it easier for T cells to fight cancer. The new cells are called CAR-T cells. The CAR-T cells are then infused into the patient to begin fighting cancer. But you can get things like cytokine-releasing syndrome, which is one of the most common side effects triggered by the immune system response. And it occurs when the modified T cells are introduced into the patient's bloodstream. These T cells start targeting cancer cells, and they release a large number of cytokines, proteins that can cause the immune system to overreact. That can lead to fever, low blood pressure, muscle pain, other flu-like symptoms, and even some severe things that can occur. You can also get neurotoxicity. Now, neurotoxicity could certainly affect nervous conduction, and we talked about how that is critical for sexual function and erections, and it could cause blood disorders, and we talked about how blood flow is so important for erections as well. Infections too, which can interrupt some of those things. So there's not a lot of studies, but the existing studies are pretty small in size, so we don't have a lot of information. But I pulled together what we do know. And so from this particular study, you can see that when people are asked to rate the severity of their sexual dysfunction, they rated it a little under 2 out of 10, with only 14.6% 5.3% reporting it as severe at 30 days or less. But then now look, when we look out a little further, 31 to 90 days, we rated it about 2.5 out of 10, with about 23% reporting it as severe. So pretty decent jump, and then some also would have reported it as moderate or mild. But then greater than 90 days, it drops back down to 5.3% reporting it as severe. But remember, you still have people reporting it as moderate and people reporting it as mild. Sexual dysfunction was brought up by less than 10% of patients, and this was a study where they looked at 40 patients at 29 centers with 15 of the caregivers and 15 experts from 9 centers. There was a diversity in age, sex, and race and ethnicity, but less than 10% of the participants interviewed brought up sexual dysfunction. So again, people don't always talk about this, but we know people can be struggling with it. So that's why we're here, to talk about it, to talk about some of the sexual issues in case you are struggling with those things, and so that you know there is help, there is hope, there are things that can really be helpful. So what are the basic causes and effects? Any treatment that you have throughout your treatment that may cause changes in blood flow, such as decreased blood cells or blood flow, could impact genital arousal, in other words, the blood engorging the genitals, and sexual function. So mostly the erections are the things that are affected in men, but also sometimes ability to climax. But the number one thing is ability to get and keep erections. Chemotherapy and radiation can both impact sexual function and fertility. Radiation therapy can impact blood flow, leading to erection issues, and it can impact nerves, leading also to orgasm issues and erection issues. Some chemotherapy may impact hormones, testosterone, and damage nerves, like some of the alkylating agents. So hopefully you're understanding a little better how the treatments may impact sexual function and cause some sexual dysfunction. So do we talk about sex? Well, our vocabulary tends to be pretty limited when it comes to sex. It may be, yes, things like that. But often we don't speak in full sentences about sex always. And we're not comfortable always talking about sex and in general. And so, but it is important for us to do that. So even though sex is everywhere in our culture, I mean, if you don't want to think about or talk about sex, you can't avoid it. It's around you in movies, in culture, on billboards. It's everywhere. But even though it's everywhere, we don't talk about it. Very interesting. Healthcare providers don't talk about it. Study after study shows primary care providers don't talk or ask about it. Oncologists don't talk or ask about it. Nurses don't talk or ask about it. And this isn't everybody, but this is what the studies show, that most people do not talk about it. In a lot of studies, greater than 90% of healthcare professionals do not talk about it with their patients. Patients don't tend to talk about it either because there are a lot of different reasons. They're embarrassed. They're like, is it okay to talk about it? Is it okay to bring it up? One patient said to me, they brought it up to their oncologist, and the oncologist was like, I'm trying to keep you alive. That's really my focus. And the person said to me, I just want to feel normal. I want to have sex. That's part of the normal human journey. Is that too much to ask? And no, it's not too much to ask. And the person was very brave to ask it, and I would hope that doesn't happen when you bring it up with healthcare professionals, because we do want these things addressed. But often patients don't tend to talk about it. Partners don't tend to talk about it either. So now we have this silence, and we have these unspoken words, but everybody's affected by it. So I think, what do you do about talking about sex? It's really important. Prepare your questions. Whenever you're going to see a health provider, prepare your questions ahead of time. Get everything ready so when you walk in there, you've got your questions written down, because when they start talking and everything starts happening, often you may forget about the things you wanted to ask about. So have those questions written down and ready to ask your healthcare provider. Plan when and where you want to talk about sex with your partner. This is tricky too, because right in the middle of sex, it may not be the greatest moment to say, hey, I wanted to talk to you about orgasms or something. When you're in the heat of the moment, it may not be just the greatest moment to talk about it. So outside of there, maybe sitting down and having a discussion. Hey, I really care about you. I really love you. I want to satisfy you. It really matters to me that our intimacy and sex life is fulfilling for both of us. And I want to talk about it a little bit. And so I think that can be really, really important as well. Lack of communication causes misperceptions. Our mind never stops. That voice in your head never stops talking. And when it has to fill in the blanks because you haven't had the conversations, usually the things can be negative the way we fill in the blanks. So misperceptions often happen. Here's a great story about that. I had a patient and their partner come in, and he was coming in to seek help for his sexual health issue, but they were having sex, and he was struggling with his erections. So in the middle of sex, she's like, they stopped for a minute, and he's like, oh, and she's like, what's going on? And he said, well, I am seeing someone, and she cracks him across the head. And he's like, I don't get it. Why did you hit me? And she's like, what do you mean you're seeing someone? And he's like, I mean, I have an appointment scheduled to see someone for my erectile dysfunction. And so you can see how two people can perceive things completely differently. So the poor guy got cracked across the head because she thought he was seeing someone else sexually, and he was trying to tell her he was seeing me. He had an appointment coming up to address the issue that he was having while they're having sex. That's why sometimes during sex is not always the best time in the heat of the moment to talk about those things, because a lot of things are going on in the bedroom at that point or wherever. What are the obstacles to talking, communicating about sex? Well, a fear of not being able to perform well. Performance anxiety is real. Anxiety is adrenaline. If you start worrying about sex, if you start freaking out about sex, you don't even have to look down. I guarantee you're going to lose your erection because anxiety creates adrenaline. Adrenaline is part of fight or flight, and it makes erections go away. So performance anxiety creates a real physiologic response that makes your erections go away. If you've had issues in the past, it's hard not to worry about it. But you try to redirect your mind back to sex, and you can't go over to what's it doing? Oh, my God, I lost it before. You can't go there. You have to stay on sex, and nothing but sex. So, but that fear of not being able to perform is one of the obstacles. I don't want to talk about it. I don't even want to think about it because, what do I know? Some people think that, well, what does anybody know when they get into the bedroom? Nobody knows much till you learn and you discover. So, yeah, or you read, or you go to presentations like this. A lack of comfort talking about sex historically can make it more difficult. The less we talk about the sex, the more we avoid issues like this and other issues, sexual issues. It doesn't usually help to avoid. Usually we need to, the more we do it, the better. So the more you talk about sex, the easier it becomes, the easier it is to talk about it. And professionals are out there to help you. I'm board certified as a sexuality counselor. There's sex therapists, there's sex counselors, there's sex educators. There's lots of people out there that can help with this. There's some great resources from the American Cancer Society and other groups as well. I'll give you a couple resources you may not have at the very end too. So talk about it. Like we're doing today, we're talking about it. We talk about it all the time in my clinic. So and it's great. And so feel free to ask your questions and talk, and we will get to those. So what can we do about it? That's important too. What are there things we can do? Well, certainly. Sometimes just learning psychosexual education is empowering. It's important. It's a really big deal. And so I think it's really important for you to understand how your body works. I've had people that I would get out a mirror with some of my female patients, and they're like, I have never even seen my vulva or my vagina. We can actually take a scope like we do to look up inside, and I can put an image of that up on the screen for people to see. Same thing. People are like, well, what's under my testicles? And I can show them the perineum and things like that you can't easily see. So oftentimes people may have, and men are pretty familiar with their penis and their body in general, but they don't always understand how it works. And so they'll come in thinking, oh, I have erectile dysfunction. It's got to be, I think my testosterone's off. That's rarely the reason for erectile dysfunction. So I think information and knowledge is empowering, and I hope you feel empowered with some of that after we finish today. So behavioral therapies, working on things, because if you don't get in there and work on it, it doesn't get better, it usually gets worse. You and your partner working together on things. We don't necessarily, we talk in the clinic and we work on different things in the clinic, but we give you homework to do at home. And our homework's good. I always say this isn't like, things that are painful or excruciating to do at home. Sex should be fun. Intimacy should be fun. So when you do my homework, please have fun. That's really my caveat always with patients. Please have fun. Don't make it not fun. One lady said, as soon as he gets out the pills and I know we're going to have sex, my blood pressure goes up. That doesn't sound like fun to me. So we don't want that. We want a culture that's fun. Counseling. Sometimes there can be issues. Believe it or not, 1 out of 3 women and 1 out of 4 to 5 men have been sexually assaulted in their life. Counseling can be important. Sometimes getting over the hurdle of, I kind of have a little bit of, I kind of have some anxiety about sex because I've had problems in the past. So counseling, behavioral therapies. When you're in your best health in terms of cardiovascular health, now you're having better blood flow. So diet, exercise, weight control are monumentally important to sexual function. They're not the only thing, but they're amazingly important. So a good body mass index, a good height-weight ratio, a heart-healthy diet. If it's good for your heart, it's good down below for your erections. Regular exercise, starting slowly with a few minutes a day and working towards about 150 to 200 minutes a week, 150 to 200 minutes a week of cardio. It's all about your heart. If it's good for your heart, it's good for your penis because blood flow to your penis is critical. It can be of course we have hormonal therapies for men, testosterone and things like that, the vacuum device, we have pharmacological agents, we have pills, we have inserts that go in the penis called intraurethral suppositories, we have injections that go into the penis, we have surgeries. We're going to talk about herbs. There are a few herbs that are out there that have some science behind them. Most of them do not, so be very careful because most of the herbs in general don't work as well as the medicinal things. But there are a few things like Korean red ginseng and L-arginine and L-cisteine that can be helpful and do have science, but they're still not usually as efficacious and have the rigor with the scientific rigor of things like PDE5 inhibitors, like phosphodiesterase 5 inhibitors like sildenafil, Viagra, tadalafil, Cialis, vardenafil, Levitra, and so on. And so, but there's everybody out there wants your money, so be really careful. I'm going to talk a little bit about that because even some of the clinics, they're after your money. Most of the things don't work, and some of them can be dangerous. But there are a few things out there that have a little scientific rigor, but not a lot. And so we are... So be careful when you're seeking medical care. In general, men go to urologists or the urology community, urology professionals, advanced practice nurses like nurse practitioners, clinical nurse specialists like myself, physician assistants, people who have expertise in urology, which is expertise in what is normally referred to as male genitalia, penises, scrotums, testicles, and so those are the expertise of the urology department. I'm board certified in urology, so all of urology, but especially sexual health. Beware of herbal remedies because they're not regulated. And again, there's a couple things. The main things out there that have some, a little bit of scientific evidence to support are Korean red ginseng, and which is Panax ginseng, as well as L-arginine, L-cisteine, things like that as well, but you have to be careful of those things. We used to use something called yohimbine, but it caused some cardiac side effects, and that came from a bark of a tree, so you think natural's better, but it actually was causing heart issues with people, and so we no longer use it. So be very careful because things in nature can kill you. Remember, some of them can be poisonous, some can cause problems. So just be careful and realize that a lot of people don't realize the FDA has enough trouble keeping up with drugs. They don't keep up with herbs at all. Beware of men's clinics. These are cosmetic clinics typically. They can work on your face. They can work on your penis all in one visit. So be really careful because they do a lot of different things. Sometimes they're called youth clinics, men's clinics. They advertise well. They promise manhood, enhanced performance, all kinds of great things. and I'm not saying they never help anybody, but I've had a lot of patients spend a lot of money for nothing with them. What men like about them is they're quick and easy access. They have substandard evaluations. You should have a physical exam, a history and physical. My visits are 1 hour long for all my new patients in the VA. So every patient I see for a full hour, their partners usually come with you. It's an in-depth evaluation. It's not done over the internet. So it's important to be fully evaluated. In general, we find poor care, which is provided by non-urology trained professionals. You'll see their billboards all over Chicagoland, where I live. You'll see their late-night TV ads. They will zap your penis. They'll take blood out of your arm and put it in your penis. They're doing things that are not yet FDA approved and not shown to work with men with significant erectile dysfunction. I've literally seen men spend thousands of dollars on these things. One man said he spent $15,000. I've had quite a few say they spend $3,000, $4,000, or $5,000. These are retail men's clinics, and they have 85,000 plus visits annually, and online 100 to 250 million annually. They utilize unproven treatments, and I love people to help people, but I hate people to waste money. I am one of the cheapest people you will ever meet in your life, so I hate when people waste money on things that aren't helpful. So be really careful. There's a lot of people out there who want your money, and they know you're desperate. And so go to urology-trained professionals or sexual health experts, and usually that means urology-trained. So is fertility? Yes, treatments like chemotherapy affected by different treatments. So yes, chemotherapy, radiation, transplant, and surgery can impact fertility. So remember, if you're going to have these things, you may want to sperm bank prior to your treatment. It takes about 72 days for your sperm to mature and be ready. And so remember, it's going to take sometimes months, sometimes years after treatment, and you want to know that you have sperm banked and you've done that ahead of time if possible. Damage may occur to sperm with chemotherapy or radiation, so it's not recommended to impregnate a partner for a full year following treatment. Some people wait 2 to 5 years after transplant for optimal sperm recovery, but it can be recommended that after a year you can move on. So a little bit about fertility. I could talk more about it if you have questions. We have a lot to cover, and I'm going to try to wrap it up in the next couple minutes so I can answer your questions. Desire. We talked about it earlier. That's the sum of the forces that lean us towards and push us away from sexual behavior. So that's what makes you go, I want to have sex. I have this strong desire. That's what we're talking about. Some people think of it as libido. It's about sexual thoughts, about forces that push you towards sex. It's a subjective and motivating feeling. And it's triggered by both internal and external cues, which may or may not result in overt sexual behaviors in sex. So drive is biologic. It's hormonal. It has to do with dopamine and serotonin in your brain. But it also has to do with expectations, culture. You've been taught what's okay, what's not okay maybe. But then your desire may not line up with that. Is something wrong with you? No, not necessarily. The culture it says things and comes up with norms that may or may not fit with you. And so then that causes conflict for you. And it might be appropriate to see a counselor or work with somebody, because it can really cause some distress in people when they're like, well, what I want sexually and what happens to me sexually doesn't line up with what I've been taught is okay or what's right sexually. But what you've been taught and what society or religion or whoever says is okay is not necessarily what's okay and right for you or others. Motivation is really important. So your beliefs and values come into play and can become in great conflict with your sexual identity, with your sexual performance, with your sexual preferences. Motivation is a big deal too. So when you're exhausted and fatigued and you're going through these really hard treatments, your motivation for sex may be low. When you're depressed or anxious, your motivation may be low. When you're in the middle of dissertations and things like that, your motivation may be low. So motivation, expectations and wishes and drives all come into desire. So I think that's important for us to remember when we pull those things apart to see why or how is desire affected in you. Now, I told you hypogonadism means low testosterone blood levels, as well as we talked about those symptoms already, so I don't need to go over them, but they're listed out for you now. Low sex drive, hallmark. That's a hallmark one. Decreased spontaneous erections also. That means the erections you get every day. Your penis literally goes up and down while you sleep to keep itself in shape when it's working right. That's why you wake up with P erections. I know you guys know what I'm talking about because this is life as a male. From the day you're born till it stops working right, you wake up with erections in the morning, at night. Your penis mostly goes up and down while you sleep. It literally goes up and down about 4 to 6 times a night. It's erect about 2 hours or so out of every 24-hour period, roughly, give or take. But your penis literally exercises. The smooth muscle and the blood flow changes within your penis as you go from hard to soft. And so that's critically important. So those spontaneous erections, when you're not trying to have sex, and there's all the other things that come into play like anxiety and stuff, when those are affected, that could be a symptom of low testosterone. Decreased energy or mood, poor concentration, reduced muscle bulk or strength, increased body fat, so fatty weight gain, decreased physical performance. I talked about those earlier, but they're listed out. Testosterone replacement has every bit as many negatives as it does positive. It's a controlled substance for a reason. I've seen people who have been on it for, usually within a week or two, you kind of know if it's helping or not, and have said, wow, I forgot how it even felt to feel this way. This is a person who it's probably really helping. You have to meet certain criteria. You have to have a certain low blood level, and you have to have symptoms accompany it for your insurance to pay for it. And you have to have 2 early morning testosterones, because your testosterone builds up while you sleep. So after you sleep, when you get up, that's when your testosterone should be drawn, and it has to reach a certain level to be normal. If it's below that threshold and you have symptoms, then your insurance sometimes will pay for testosterone replacement. But it's a hormone, so it has good and bad. That's why you'd see ads during a football game, and you'd say, if you have low T, call us, and you should ask your doctor and start on testosterone replacement. And then 5 minutes later, you see an ad that says, if you had a heart attack, a cardiovascular event, a stroke, or a heart attack, and you'd like to sue your doctor, we will help you do that because you were on testosterone and weren't monitored well. So testosterone has good and bad. Make no mistake about it. It has to be given like every treatment, with correct supervision and to make sure that everything goes okay and safely. And it can be done that way, but it can be a little tricky because it has good and bad. Testosterone is not recommended in breast and prostate cancer patients, or if you have an abnormal digital rectal exam or elevated PSA or prostate cancer as well. We talked about if you have high hemoglobin blood counts, because that means the blood is a little viscous and you don't want to put testosterone, which can make it more viscous, leading to heart attacks and strokes, hence the lawyers jumping in. Untreated severe sleep apnea, severe prostate issues like benign prostatic hyperplasia as well as prostate cancer, uncontrolled heart failure, and if you are trying to father a child, because testosterone can cause infertility. When you're on it, you usually don't produce sperm. So there's injections, there's topicals, which are the most popular. Injections are the classic way. You usually get an injection every other week or every week. Topicals are gels or patches. And in addition, there's a patch that goes in your gums, in your mouth. There's a pellet that goes under the skin and is placed in the clinic. And there's also now testosterone pills. So lots of ways to deliver testosterone. So there's other ways to reclaim desire as well. Because desire is not just about testosterone. So anticipation in the mystery. Maybe this time we'll have oral sex or manual sex, or maybe I'll manually stimulate the clitoris, or she'll manually stimulate my penis, or he'll manually stimulate, or whatever. So whatever you like, the mystery can be fun. And you need to feel like you're worthy, and like that you are worthy of pleasure, that you're worthy of feeling sexual satisfaction and desire. It's difficult, but we try to remove all the guilt, the blame, the pressure. It's nobody's fault when you have erectile dysfunction. It's nobody's fault when you have difficulty climaxing. It's nobody's fault if you have pain during sex. The essence of sexuality is giving and receiving pleasure, oriented towards touch and connecting with each other. So the goal is deep connection with your partner, for many people who are partnered, and pleasure. It's supposed to be fun. Procreation can be the one other thing as well. It requires intimacy, pleasure, mystery, and eroticism. So, and it's kind of developing this whole yours, mine, and ours bridge to desire. Working together towards desire can be really important. So we want to think a little differently about intimacy. It's not just, we're kind of taught and programmed. Okay, in terms of foreplay, it's about breasts and genitals and everything but intercourse, but we're always headed towards penetration with a partner, whoever the partner is. That's where it's headed. We're sort of programmed that way, but it's not the only way. There are many, many ways to experience sexual pleasure. Manual stimulation of the genitals or other erotic zones in the body, oral stimulation of the erotic zones, toys and things, vibration, different things, as well as penetration of partners or a partner. The excitement comes from the anticipation and the mystery of where the intimacy will lead to today in this particular circumstance. It may be different today than it was yesterday. It may be different tomorrow. That makes it exciting. Intimacy is connectedness on all levels. It's really connecting deeply with your partner, and it's a part of this. So we're not connected well when we're freaking out or anxious about things, or if we're afraid to even kiss or touch or be affectionate because we're like, oh my gosh, they might expect something, and I know my penis, it's not working right. It's, and it's like, so now you stop hugging, you stop kissing, you stop connectedness. And if you have a partner or a spouse or whatever, they're like, what's going on? Why aren't we connecting? Why aren't we even being affectionate? But it can all fall apart because of sexual dysfunction sometimes. So we have lots of different things. We have the vacuum constriction device where you put your penis inside that cylinder that you see here. That cylinder is where your penis goes. And then you pump the pump. And when you pump the pump, it creates a suction inside there to make you harder. Once you get harder, there's a ring. You can kind of see it on the edge of the device that you push off the edge of the device to the base of your penis. It's completely non-invasive, and it's physics. It forces more blood in your penis, and the ring traps it. And so it works in about 90% of patients. But it's cumbersome. It's awkward. You have to wear a ring during sex. It's far from perfect. Perfect is you think it, and without much provocation, there's your erection. You know what that's like. And I wish I could give that back to all my patients. If I could do that, I would be the most popular man on the face of the earth. I guarantee you that. But we have to work with what we have. So we have the vacuum pump as our most non-invasive. That's why I started with it. It's not the most popular. The pills are the most popular. And we have lots of pills. We have sildenafil, vardenafil, tadalafil, avanafil. We have multiple pills. Most of them are taken on demand before sex because most people don't want to take a pill. They don't want to take a pill every single day when they're not having sex every day. So most of the time it's taken on demand for sex about an hour or two ahead of time on an empty stomach. Avanafil gets in twice as quick, so it's usually taken about 15 to 30 minutes ahead of time on a fairly empty stomach. They're easy, they're discreet, by a landslide. They're the most popular. I can answer questions about them. I teach people how to take them all the time. Food and fat can delay absorption is really important. So most of them, even though they may say you can take it with food, they work better on a fairly empty stomach. And for sildenafil, vardenafil, and tadalafil, they take 30 to 60 minutes just to get in and about an hour to 2 hours to give you the full effect. So those are some little pointers or tips about pills. When pills don't work, some people are like, I don't want to deal with any of that. The vacuum pump, the shots, none of it. Some people move on, and the second most popular was the vacuum pump. Muse has not been available. It's been on back order for about 1.5 years or more, almost 2 years now. It's a urethral suppository, and they came up with it because men said, oh my gosh, I don't want to give myself a shot in the penis. That just sounds god-awful. Even though it's a super small, super fine needle, it's still a weird thing to do to yourself. And some men were just like, there's got to be another way. They tried every other way, and the only thing they come up with is a little rice-sized grain suppository that goes down the wet urethra after you pee. So you put it down the urethra like you see there, and it goes down inside of the urethra, and then after you put it in, you take the applicator out, roll between your hands, and it dissolves. It only works in about 40-45% of patients, and I think that's why it's not super popular. It's very expensive, and the drug company has still not yet, after almost 2 years, brought it back to market, but it's supposed to be coming back at some point. We do have patients on it, especially at the VA where I work, because we are allowed to give them 2 of these a month for free, as part of their benefits or with their copay. And so we do have a lot of patients on it there and are waiting for it to come back. In the private sector, I had very few people on it because because it doesn't work for most people, and they cost about $100, $150 a piece. The shots can cost the same amount, but they do work in 70 to 80% of patients, which is a lot better than 40 to 45%. So they work in most patients, not everybody, but now you have to give yourself a shot each time you want to have sex. But they do work for most patients. It can be done safely. It does have side effects. I can talk more about it if you want. I've taught thousands of patients to use injections and to use the vacuum pump over the years, so lots of people to use all these therapies for many, many years. You can also have a penile implant, which is literally like a replacement of the mechanisms in your penis. So they put cylinders in your penis, a pump in your scrotum, a reservoir in your abdomen. When you pump that pump in your scrotum that feels like a third testicle, it moves the fluid out of the resting chamber in your abdomen into the chambers in your penis to make your penis hard. And when you're done, you hit the release button and the fluid goes out of the penis chambers into the resting chamber. It's permanent. It's a huge step. Only about 1 to 2% of men who have erectile dysfunction will go on to do a surgery, but it does work. It goes where you go, and it's still an option for people, but it's a big step and it's a permanent step, because like a knee replacement, if we take it out, just like you took out your new knee, you'll never be the same again. So you got to understand, it's once you cross that bridge, it's challenging to come back. Okay, you can also have ejaculation disorders like premature ejaculations. So men for years have used things like distraction. 27 divided by 3 is 9, 9 divided by 3 is 3, so on. Positioning. Men usually last longer on the bottom because the friction's different. If you last longer on the bottom, start on the bottom if you have premature ejaculation and move to whatever position you want when it doesn't matter anymore. Stop-start method. I don't like the squeeze technique because if you squeeze the penis right before it goes, it usually goes. A recent climax, if you haven't climaxed for a week or two, you're going to climax quicker. So some men will masturbate in anticipation that within 24 to 48 hours they will have sex with a partner and they can last longer. Or they'll turn around and have sex again if they lose it. But as you get older, that period between getting an erection after that may last longer. But a recent climax. Layered condoms. So wearing a condom or multiple condoms can decrease sensation. You can use numbing agents, but they will numb your penis, like Promescent, and they can transfer to your partner, especially the ones that come inside the condoms. They do get on partners, then everybody's numb. Nobody's having a good time. Medications like antidepressants, for off-label use have been shown in studies. Things like sertraline and clomipramine and paroxetine have been shown to delay time to climax because they change dopamine and serotonin levels in the brain. If you have delayed climax, sometimes vibratory stimulation can help, even in spinal cord patients. Sometimes it helps, sometimes it doesn't. So my key points are sexual dysfunction is common after transplant. It is quite common. Most of the men reported it in the studies. Sexual and intimacy issues can be addressed. There's help. We can help you. Communication is critical, and learning to communicate about sex with your partner and others is really, really important because it's often not talked about. It is possible to have an incredibly fulfilling, enjoyable sex life and intimacy after cancer treatment with the help of expert providers. I hope that information has been helpful. I do have videos on many of those treatments. I used to work at North Shore, and they have a whole video library still there. That's the link to it. If you put in North Shore Sexual Health Albaugh, you'll find my videos. I have a whole group of videos for men and a whole group for women. Sexual Health Matters is the Sexual Medicine Society group, and there's lots of information on there too. So resources for you as well. As my answering your questions, any brave souls who have questions, and I see one there, and it says, what's the difference between tests for
Dr.
testosterone?
Albaugh, I can help moderate the questions for you.
Okay, go for it. I'm ready.
So, absolutely. So what is the difference between tests for free testosterone and total testosterone, and which is more important?
Okay, so total testosterone is a very basic test. It's a great test to look at how much testosterone is in your body. And it's a hallmark test that your insurance company wants us to look at in terms of, do you have hypogonadism, and are you going to be eligible and reimbursed for treatments or eligible for those to be covered by your insurance. So it is important. Free testosterone is actually the testosterone in your body that's unbound to proteins and things and actually does the work in there. So often, as a first test, they will do a total testosterone. And then if you're having symptoms and they haven't discovered everything, they may also look at a free and a total, which will also give them a percent free. It'll give them a lot more information about the testosterone that does things in your body. They both can be important and they both can be valuable. It's a more advanced, more expensive test for a free and total, and it has to go usually to a special lab that has the right equipment to do it. So that's why it's not done as a basic beginning test. But it can be done at some point. And at some point, if you're really struggling, especially with desire or libido issues, it can be important to get that free and total testosterone panel, because it does give us information on all the testosterone in your body, and in particular the testosterone that does the work in your body, which is your free testosterone.
Awesome. Thank you very much. And we have about 4 minutes left, so I'm going to bundle together a couple of questions related to ejaculation and semen volume. So could you please talk about the effects of transplantation and CGVHD on the effects of semen volume, and does watery semen mean that they don't have viable sperm, and could this semen count improve in the future?
So these are excellent questions, and they're great fertility questions. So remember, several of the treatments that you may have gone through, if you had radiation, if you had chemotherapy, if you had a transplant, if you had all of the above, all of them could have an impact on your semen volume and your semen production. So that's why I say it is important to sperm bank before you go in. If your semen is watery, it doesn't necessarily mean that you don't have sperm in there. The only way to really know is a sperm analysis, which looks at your sperm motility, how much sperm is there, are the sperm viable, all those different things. And as I said, it takes about 72 days. So think of it taking about 3 months for your sperm to mature and be ready after some of these treatments. These treatments can slow production of sperm. It can halt production sometimes. It just depends. And so that's why we always tell people, go in knowing that this may affect it, and why the recommendations usually say to wait a year to impregnate afterwards. And some people even wait longer to see if the sperm volume comes back around, if the sperm production comes back around. And remember, we also need motility, we need movement, we need the sperm to do all the things it needs to do to survive in the acidic environment of the vagina and vulva, and also to get where it's got to go and impregnate your partner. So great questions, and you should have, the only way to really know are sperm analysis, what's going on.
Awesome. I think we have time for 1 or 2 more. Is it concerning if someone's partner is using an estrogen vaginal cream that comes in contact with the penis during vaginal penetration?
Great question. Many women have trouble and struggle with not enough local estrogen. So they use a local cream or a tablet or a ring. All of them work equally well. They should be using those during non-sexual times, and they in the perfect world clean those off well before you're having sex. It's not going to probably cause much of a problem for a male to come in contact with it, but I've actually inadvertently had people use it as a lubricant. Your partner should not use that as a lubricant for friction, because it's not going to be a good thing for your male partner or people with penises to have come in contact with the penis. It's not going to cause a major issue. I wouldn't freak out if it happened, and trust me, I've had people who've done that, used it as a lubricant, and it's been okay. But you don't need the estrogen, and it is transdermal. It will absorb in your system. So those should be used on non-sex days or cleaned off before sex with a partner when a penis is going to come in contact with that.
All right. And I think our last questions are, does exercise help your sex drive, and are sexual function problems permanent? And can you get back to the same sex life as you had pre-transplant?
So if I'm understanding, you're saying, is exercise helpful, which I said definitely exercise can be helpful. Remember, it's not necessarily going to reverse some of the things that have happened from your treatment, but in general, we need good blood flow, we need good nervous conduction, and we need you to be healthy. So you can never go wrong once you're cleared to do diet, low fat, low cholesterol, low fat, low cholesterol, low carb, high fiber, plant-based, lots of fruits and vegetables, minimal red meats and animal fats. If you eat red meat, the leanest red meats you can. If you and then exercise, beginning with a few minutes a day, working towards about 3 hours a week of cardio. Cardio is what it's about. You can walk, you can run, you can elliptical. But if it's good for your heart, it's good for your body. And getting your body back in shape is important, and your penis needs the blood flow. So, but will it correct everything? Of course not. With my patients who've had radiation, surgery, chemotherapy and stuff, it can't always reverse what neuropathy or nerve damage has done. Being healthy can do a lot of things, and I wish you could fix all those things, but it doesn't. It's not necessarily going to fix things like nerve damage or permanent blood flow problems. So, but it can't hurt, and if you've been cleared and are ready, it will likely help. I've seen it turn things around dramatically. When they were like 40, 50 pounds overweight, they got really healthy. They saw big differences in spontaneous erections, night erections, morning erections, erections with partners, erection with masturbation. So it is probably the most important thing you can do for yourself in terms of getting yourself in good shape, cardiovascular-wise and sex-wise. I think that answered the question. Was there any more to it, or did I get it all?
Absolutely. There are more questions, but unfortunately we've run out of time. But I just want to thank you so much on behalf of BMT Infinite and our partners for your extremely helpful presentation, Dr. Albaugh. I think that this is such an important topic for us to feel confident talking about and sharing our concerns and really searching for answers with each other. So thank you.
I know real quickly, I saw in there about the CAR T-cell therapy real quickly. So if you may, I'm not sure if you saw that part, whoever asked the question, but there's very limited studies and information. And so that's why probably you weren't advised about the sexual issues and stuff. But you can see from the study, from what the slide that I have in there on CAR T-cell therapy, that some patients do report problems, but there's very limited information. And so, when you think about if you have the side effects from CAR T-cell therapy, like the cytokine release syndrome or the neurotoxicity specifically, or blood disorders, when you're having those issues, that could affect blood flow or nervous conduction and could affect your erections. So that's what I would say at this point, how it would affect it. And but we don't have a lot of information because there's very limited, very small studies at this point, and that's probably why you weren't told much about it when you had that therapy. And that's why I wanted to talk about it today with at least what we do know. So I hope that was helpful to you. I'm sorry if I missed some of your questions. I'll try to stay on there and answer them if I'm able to, writing things in there, but anyway.
Awesome. Well, thank you again to you and to the audience for some amazing questions that I think are helpful for all of us. To everybody, please contact BMT Infinite if we can help you in any way. And thank you, and enjoy the rest of the symposium.